A very good afternoon to all of you. And after that short break and the introduction, I bring to you the basics of thyroid FNA and the benign lesions. Now, both these topics are quite important because the benign lesions, as you know, form the majority of cases that are sampled. And for a proper sample, you need to have your basics right. Okay? So what we'll do is we'll start with some technical considerations regarding FNA of the thyroid lesions. That is some prerequisites and precautions to be taken during the procedure. And then we'll move on to the Bethesda system, categories 1 and 2. Now let's directly go to a patient who has a thyroid enlargement. Now besides the clinical details, he is given a list of investigations which include TSH, ultrasound and FNA. Now always remember that this biochemical, radiological and cytological findings should always complement each other. Why is this not moving? Now TSH helps us identify a functional nodule. Madam has already given you all an idea about it. So these functional nodules are firstly rarely malignant, and secondly, many of us who have done it, we know that it may once in a while trigger a thyroid storm. So FNA in a hot nodule or a functional nodule is best avoided. This is especially for the residents who go there to do FNA. And in case it is the TSH is within normal limits or it is raised, and in a cold nodule or a non-functional nodule, the patient goes for an ultrasound where it is verified whether a nodule is there or not. And secondly, if any suspicious features are there, it is seen whether it meets the TIRADS criteria based on which FNA is done. FNA is recommended. So a word about this TIRADS, because we always, when we are reporting, we tend to correlate with the USG findings. So TIRADS or Thyroid Imaging Reporting and Data System is a standardized reporting system on ultrasound, and it is for thyroid nodules, which evaluates various characteristics of the thyroid nodules and scores them. And the suspicious features include, firstly, a predominantly solid nodule, which is very hypoechoic, which has a taller than a wider dimension. That is, the vertical dimension is more than the lateral dimension. Something is wrong with the... If the margins are irregular and if it has extrathyroidal extension, it directly gets a 3 point. And if there are punctate echogenic foci, again there are 3 points. So these points which are given here in these columns, these points, all these points, depending on what is there, they are summated or total is made, and this determines the TIRADS score. Now based on this score, the lesion is graded and further management is recommended. Now TIRADS can be from 1 to 5. TIRADS 1 and 2, they have a very low risk of malignancy. You can see out here. So FNA need not be done in such cases, but TIRADS 3, 4 and 5, which are mildly, moderately and highly suspicious, the risk of malignancy goes on increasing, and in these cases FNA is done. Now what are the advantages of ultrasound? Firstly, it will help us localize the lesions. Secondly, it helps detect any further nodules which were not palpable. They can be also found on ultrasound, and it also gives us an idea about the lymph node status. But the limitation is that often the lesions have overlapping features, so it is not sufficiently discriminatory, so the patient comes for an FNA. Now, while performing an FNA, this I have put it in red at the bottom, that for all cytology specimens and not just thyroid, for all specimens, relevant clinical details are extremely essential for interpretation of the smears, and the features of concern in the clinical history include a rapidly growing nodule with local symptoms such as hoarseness of voice, difficulty in breathing. Always remember to ask a past history of exposure to ionizing radiation, a family history of a carcinoma thyroid in a first degree relative, and if all of this is seen in a male who is less than 20 and more than 65 plus, well, your antenna should be up. And on examination, the suspicious features include a solitary thyroid nodule, which is firm to hard, fixed, infiltrating adjacent structures, and if cervical lymphadenopathy, be on your guard. Okay, now coming to the technical considerations. You have examined the patient sitting. Ask her to lie down in the supine position, and this pillow should be pushed below the shoulders for hyperextension of the neck. Now, this will make the lesion more obvious, and in a vascular structure like the thyroid, and remember this, it is applicable to all vascular structures, fine needle capillary sampling, that is without aspiration. You can see one of our residents was doing this, that without aspiration, a fine needle capillary sampling is anytime preferable. Use a 25 to 27 gauge needle. This will minimize the trauma and the smears will be less hemorrhagic, and ideally, thyroid FNA should always be done under USG guidance, but as it is not always feasible, we can do it under guidance, especially when the initial FNA is inadequate or indeterminate. And if the lesion is solid, cystic or complex, to localize the solid area, there's nothing like a guided FNA, and a deep-seated small nodule, you will always require a guided FNA. Now there are some prerequisites prior to the procedure, during the procedure, and after the procedure. And always remember, before you start the technique, always remember to instruct the patient not to swallow or speak. It will increase the bleeding out there. During the procedure, the needling process should be as brisk as possible and as gentle as you can, because it being a vascular structure, do it very roughly, it will bleed, and as soon as material appears in this hub of the needle, stop the process. And if you do aggressive FNA, there may be bleeding and hematoma formation. But if the nodule is small and situated in the isthmus, you will go down, you will puncture into the trachea, the patient will cough, so you will pull out the needle, and all we get in the smear is ciliated columnar cells. Now, if it is a cystic lesion, if the sonologists tell you it's a cystic lesion, prefer a 23 gauge needle. Always evacuate the cyst completely and then re-aspirate any residual mass. Residents, please remember this, and then prepare smears from the residual mass. Note down all the details of the fluid, and the fluid can be sent for centrifugation, and the smears can be prepared from the pellet. After the procedure, okay, and for representative samples, always remember in a solitary thyroid nodule, if it is especially more than 3 centimeters, aspirate from different sites. In a multinodular goiter, aspirate several nodules, and always tell the sonologist to avoid guiding you straight into the center, because at the center you have the necrotic regressive changes which complicate the picture. And if you have access to a rapid on-site evaluation, it will be really helpful in assessing the adequacy. Now, post-procedural, quickly put a gauze pad at the site of the FNA. This will, it tends to bleed more, and when the patient comes for the report, often the residents must have faced it, that they show you the patch of hemorrhage and hematoma which is formed out there. And immediately, rapidly prepare and fix the smears. This will avoid clot formation and it will decrease the cell distortion. Half the smears you fix it, half of it you keep it as air dried. If you have scanty material, 1 or 2 slides, always prefer to air dry it, because MGG you will get 100% cell retention, and the extracellular material, that is colloid and amyloid and the cytoplasmic features, are best seen in the MGG. Now, I have gone into such technical details, it's because so that we can reduce this unsatisfactory category, which is the first diagnostic category in these 6 categories of the Bethesda system, which is for reporting thyroid cytopathology. And why do we need a system for reporting? Basically, it is to convey whatever we have interpreted in a clinically useful manner based on which the management can be planned. And as Madam has already mentioned, each thyroid report should begin with a general diagnostic category. After that, you can put in whatever you want. Now coming to a thyroid aspirate. So when do you call it non-diagnostic? When do you call it satisfactory? For that, you need to assess the adequacy. And what is the criteria for adequacy? It is a minimum of 6 groups of well-visualized follicular cells with at least 10 cells per group. Now you don't have to sit and count each group that you are seeing. Here I have counted this for you all. There are about 13 cells here. So it should be well visualized, means it should be well stained, it should not be obscured by any material, and it should not be distorted by drying or any such artifact. And if you have a large sheet, you can break it up mentally that whether it fits the criteria or not. Now coming to the non-diagnostic, it can be numerically inadequate. If it is acellular, no question, it is non-diagnostic. Sometimes it can be numerically adequate but technically unsatisfactory. Sometimes it can be technically satisfactory, numerically adequate but not representative. So in this first case, no follicular cells, no colloid, inadequate, non-diagnostic, no problem. In this second case, cells are there but it is obscured by abundant blood. And in this case, the cells, so this would be unsatisfactory, and in this case, the cells are entrapped in a clot, the morphology is indistinct. This is probably a delay while preparing the smear and fixing it. So this too becomes unsatisfactory. Now whether it is non-diagnostic, inadequate, unsatisfactory, all of it implies that it is insufficient for diagnosis. So adequacy is not just dependent on the inherent nature of the lesion, it depends on the technique. Quite a lot on the technique. So attention should be given to technical details, and I am repeating myself, use a smaller gauge needle, avoid negative pressure, brisk sampling, and rapid smear preparation. In the first case, put the general diagnostic criteria and give the reason and advise a repeat. In these two cases, it remains the same, but the reason changes. Now sometimes you may get predominantly non-thyroidal tissue. I've already told you about puncturing the trachea, and this was one case which I myself have done, and I've punctured the trachea, and you can see the ciliated columnar cells out here. And sometimes if the lesion is further placed under the sternocleidomastoid muscle, you may pull out the muscle, which is very painful for the patient, and you can see that the muscle is there for you to see. Now, sometimes the sample may be only cyst fluid which is aspirated. Here you can see granular debris, plenty of dispersed macrophages. It could be mononucleated, multinucleated. Here you have cholesterol crystals, hemosiderin-laden macrophages, but it is totally devoid of colloid and cells. And remember, macrophages do not count towards adequacy. So you give it as non-diagnostic, describe it, and always recommend correlation with the cyst size and complexity. Now to every rule there will be exceptions. That is, a minimum number of follicular cells are not required in a solid nodule with cytologic atypia. That is, can you see this groove out here, nuclear groove, some hyperchromasia, anisonucleosis, lot of atypia, but if the cells are few in number, even then at least report it as an atypia of undetermined significance, which Madam will be covering, and this needs to be repeated and followed up. In the case of thyroiditis, if there is inflammation, you don't need to have the minimum number of cells. The inflammation has already damaged the follicular cells, so it can be interpreted and reported as benign. And in a colloid nodule, when you have only colloid in the proper clinical setting, you need to correlate with the ultrasound findings, and then you can consider it satisfactory and benign. I told you about being a technically satisfactory, adequate number of cells, but not representative. This was a case in which the initial FNA showed abundant colloid follicular cells, and it was suggestive as such for a colloid nodule. But on USG, it was a moderately suspicious lesion. So a repeat guided FNA was done. The cyst was evacuated, and FNA from the solid areas, it confirmed a papillary carcinoma. So that was, everything was right with it, but the lesion had not been reached. So after the non-diagnostic, when you see satisfactory aspirate, always assess the basic components, the colloid and the cells. Now the colloid can be thick or thin, and the cells we'll see after this. The thin colloid appears like a varnish-like coat, best appreciated in the MGG stain. It can range from blue to purple to magenta color, and on drying, sometimes during processing, the the colloid may get washed off, but you can identify the colloid at the periphery by, after drying, it forms such cracks and folds. You can see it here. Even you may have lacunae. You have very nice chicken wire appearance, mosaic pattern, and this really looks like the crazy pavement. And the thick colloid may form such irregular clumps of acellular homogeneous material. Sometimes it can have such dense spherical structures, and then often the resident asks, is it a Samoma body? But always look for the concentric laminations within, and you will be able to differentiate the two. I've told you about the muscle. Thick colloid may resemble it, but here you will see the pale nuclei at the periphery, and if you put it on high power, you may get to see the cross striations. Collagenous stroma is more fibrillary, and medullary carcinoma, you may get amyloid, but differentiating colloid and amyloid is actually very difficult, but it is mentioned that it is not homogeneously hyaline. Rather, I would say, look at the entire picture and you will be able to identify the amyloid. And very thick colloid. Just try sticking some chewing gum onto someone's dress, and when you pull it, that chewing gum appearance, when it is thick colloid is smeared in the background, it is seen in papillary carcinoma. So it is very aptly, this very thick colloid is referred to as a chewing gum colloid. Now coming to the cells may be in various forms, in sheets, in loose clusters, in macrofollicles, but here I'll describe it here as a monolayered sheet of evenly spaced cells, you can see, with minimal overlapping, with indistinct cell borders, fragile, moderate amount of very fragile, delicate cytoplasm, and can you see this granules, coarse granules in the cytoplasm, and sometimes you can even see such faint vacuoles. If you look carefully, next time when you see a slide, just try and identify the vacuoles. And the nucleus, always compare it with an RBC. It's about the size of an RBC or slightly larger, and it has uniformly granular chromatin. And the Ashkenazi cells or the oncocytic cells, also known as Hurdle cells, in benign lesions, they are always, often I should say, they are accompanying, they'll be seen as an accompaniment, and they are polygonal cells with abundant granular cytoplasm, a central round nucleus with a prominent nucleolus. They may show binucleation and marked anisokaryosis. So based on these basic constituents, we should be able to identify normal thyroid even if it is at an ectopic site. We've got cases as a lingual thyroid, and this identification is very crucial because it may be the only thyroid tissue the person has, and once it is removed, then he has to be lifelong on thyroid hormone therapy. Now coming to the benign category, as I've already told you, majority of cases sampled belong to the benign group, and this is a heterogeneous group of entities. You can see that it is heterogeneous, and all these lesions, they have overlapping features. As the risk of malignancy is very low, the management is usually just a follow-up. Now, for identifying a benign follicular nodule, look carefully at the epithelial cells. Look at the cytoarchitecture, give special emphasis on the nuclear features. It will help you identify the benign nature. If only fluid has been aspirated, look and see where the epithelial cells are there to make sure that you're not dealing with a new nodule with cystic change. And if there is a prominent inflammatory infiltrate, it is a thyroiditis. Now let's begin with the benign follicular nodule, which is a term used for an adequate sample characterized by abundant colloid, varying proportion of follicular cells, Ashkenazi cells, and macrophages. And based on this cytomorphology and the correlating with the clinical presentation, you can subclassify it into any of these. Now, a colloid nodule, you will have abundant colloid, very few follicular cells, and I've I have already told you that in the proper clinical setting and correlating with the USG findings, you can give it as satisfactory and consistent with a colloid nodule. A nodular goiter, you will have thick or thin colloid, and the follicular cells will be in sheets, loose clusters, singly scattered, and the cytoplasm being very fragile, sometimes it is totally stripped off and all you get is lots of bare nuclei in the background and a varying proportion of your Hurdle cells, and then you can put this as a benign follicular nodule. And sometimes in such a nodule you may get such large cells with abundant cytoplasm, large nuclei. These are the hypoplastic changes that occur, and along with it you will have these involutions, small pycnotic cells. And then what happens is when these follicular cells are suspended in abundant colloid, these alterations tend to occur. They tend to dissociate, they become shrunken, they become spindled, well appreciated here, and they have a degenerative quality about them. Now macrophages, I said, are a usual accompaniment in any of the benign nodules, and here you can see many macrophages with hemosiderin laden. We've already seen it. But sometimes the follicular cells, they tend to show such vacuolar degeneration, and then what happens is sometimes a particular cell, one wants to know whether is it a follicular cell or is it a macrophage. That time it becomes very difficult, and then you can just label it as a foam cell. Now once in a while we get such fragments of micro tissue biopsies, which we will call, you can see these three-dimensional, variably sized balls and spheres of follicular cells, that is the macrofollicles. These macrofollicles, they tend to get disrupted by needling, and then they flatten out as monolayered sheets, better seen here. And remember, macrofollicles are evidence of benignity. So a large sheet pattern of follicular cells with thin colloid in the background, that is actually indicates a macrofollicular pattern. So in turn, it is indication of benign nature. And you can then put it as a hypoplastic or adenomatoid nodule. Now, within these three-dimensional spheres, always try and do the fine adjustment, and you will see that the nuclei are evenly spaced all throughout the three-dimensional sphere. And I'm stressing on this is because sometimes the smaller follicles are removed intact, and then they are enveloped by a basement membrane. You can see it out here. And then we think, is it a multinucleated giant cell or is it an intact follicle? But look for this evenly distributed nuclei. You will know the polarity is maintained, and it will help you differentiate the two. Now in thyroid, the cysts are most commonly due to retrogressive changes in a nodular goiter. You can see the same picture, debris, the macrophages, and along with it you have colloid and your sheet of epithelial cells. For a definitive diagnosis, I'm repeating that adequate sampling of the solid component is essential. So evacuate the cyst and re-aspirate under guidance from the solid area. If there is no solid area, residual solid area, and the epithelial cells do not show atypia, then it indicates benignity. Now the cyst lining cells can show such focal reparative changes, some spindling, some squamoid-like cells, and when along with it you have such nuclear megaly, finely granular chromatin, and even this nuclear grooves, then we think, are we dealing with a papillary carcinoma? Are we missing it? So I am again emphasizing on the need for adequate sampling of the solid area. I have already shown you this, that fluid with degenerated cells on USG, it was however reported as a moderately suspicious lesion. So a cyst was evacuated and FNA from the solid area, the papillary carcinoma was confirmed. Why am I repeating? Because a false negative cytodiagnosis is most commonly seen in cystic carcinomas, especially a cystic papillary carcinoma, and the risk of malignancy is higher if it is a recurrent cyst and if the cyst is more than 4 centimeters in diameter and seen in young males. Now the differentials obviously would include a thyroglossal cyst in which you will get the ciliated columnar cells and squamous cells. It can be a branchial cyst in which you will get these squamous cells and this debris in the background, and it is more laterally placed, and if it is a lateral cystic lesion, you empty out such clear water-like fluid, then always advise estimation of the parathormone because it could be a parathyroid cyst. And don't forget your cystic cervical lymph node metastasis. Now a word about Graves' disease. I won't go much into the theoretical details. I'll suffice by saying that it is an autoimmune diffuse hyperplastic thyroid disorder seen in middle-aged women, and usually they are clinically diagnosed as they have hyperthyroidism, but when they have a cold nodule and we are having a suspicion of a coexisting malignancy, then FNA is done, and always clinical and serological correlation is needed for a definitive diagnosis. And the smears, what do they show? Very less colloid. So it's a colloid-free smear with quite cellular, and you can have it in sheets or in such nice ring-like structures, and the cells have, as I've said again, quite a lot of cytoplasm, which is very delicate. And this was a slide which just came in a week ago, and here you can see the fire flares, that is these marginal cytoplasmic vacuoles with homogeneous pink material like the fire flares, and that's why it's also called a flame cells. Now this is mostly seen in Graves' disease, but it is not specific for it. It can be seen in other non-neoplastic and neoplastic conditions. Sometimes you may get such focal chromatin clearing and such intranuclear grooves. And that time again a doubt arises, is it papillary carcinoma? But these, as I said, focal and other diagnostic features of papillary carcinoma which will be discussed, they are absent, and sometimes they may even show such marked anisokaryosis and nuclear atypia. These are actually, look at this smudgy nature, then you know it is degenerative changes. All this I've taken from a known case of a medically treated Graves' disease that too came just a few days back. So now, if you have a prominent inflammatory infiltrate, look carefully, is it prominent, is it mostly lymphocytes or is it polymorphs? If it's for polymorphs, obviously it's an acute thyroiditis. Lymphocytes, look at the accompanying cells and then you will be able to identify the thyroiditis. Now lymphocytic thyroiditis and Hashimoto's, they are supposed to be different phases of an immune-mediated inflammatory disorder, again seen in middle-aged females, and mostly they have diffuse enlargement. So why do they come for an FNA? When either it is becoming very bulky or if more nodules are suddenly appear. And I've already told you that the thyroiditis are an exception to the rule for adequacy, that is a minimum number of follicular cells are not required. Now here you can see the close intermingling of the reactive lymphoid population and the degenerated follicular cells. Because of this, the follicular cells are often absent, and subtyping a lymphocytic thyroiditis as Hashimoto's thyroiditis requires clinical and serologic correlation, because in Hashimoto's, along with this picture, you will have anti-thyroid antibodies which are significantly elevated. And what is this picture that you see? A polymorphous population, that is small mature lymphocytes, the large reactive population, you have the histiocytes, the lymphohistiocytic groups. I have marked out a plasma cell, so it's a lymphoplasmacytic infiltrate that you will see, and closely intermingling and hugging these epithelial cells out here. You have nice cluster of, in this one image you can see the inflammatory infiltrate, the oxyphil or the Hurdle cells, and some amount of colloid. And if you have such a picture, and if clinically they tell you, yes, the serology, there's raised serological values of antibodies, then you can give it directly as Hashimoto's thyroiditis. And if the history is not there, always advise that it should be correlated with the autoantibodies, which the clinician then tells the patient to do. Now, Hurdle cells may show such anisonucleosis, and you can see such atypia, one here, even here you can see it. And if the Hurdle cells predominate, then in such a picture, you start thinking, is it a Hurdle cell neoplasm? Now remember that Hashimoto's thyroiditis have increased relative risk of malignant lymphoma. So pay attention to the polymorphous population of lymphocytes. If there is monotony, always work up for a lymphoma, and sometimes it can even have, they say that there's an increased risk of papillary carcinoma. You can see some grooves here and there, but other features are absent. It will be again discussed in detail. Now sometimes Hashimoto's can have such marked fibrosis, seen in elderlies with severe hypothyroidism. Now I'll show you an interesting case in relation to this fibrosis. This is of a 38 years female. She came with a thyroid swelling, shortness of breath, and the thyroid was fixed, hard. On radiology, there was a capsular breach, extracapsular invasion, and encasement of the major vessels. All of this, obviously, it was a clinically and radiologically, it was suggestive of a malignancy of thyroid. Now, what I should mention that when I was doing the FNSC, the first pass, there was resistance felt and minimum blood was aspirated. So subsequent FNA, I did it with a 24 gauge needle with aspiration, and then what we got was a reactive population, lots of spindly cells, and now you can see the fibrosis. We did it from where the extracapsular breach was also there. You can see the fibrosis extending, you can see it here, and entrapping the muscle fibers and a large fragment of the muscle bits and the fibrosis. Now first we thought, we also searched for malignant cells. There were no malignant cells anywhere. So first we thought of a fibrosing variant of Hashimoto's, but Hashimoto's does not have this extracapsular extension. Then we thought, is it a fibrotic reaction surrounding a carcinoma? But there were no malignant cells seen. So correlating the whole thing, we gave it as consistent with Riddle's thyroiditis with an advised clinico-radiologic correlation. Surgical intervention followed to relieve this patient of her symptoms, and it was confirmed as Riddle's thyroiditis, which is an extremely rare chronic fibro-inflammatory process in which the fibrosis invades the adjacent tissue and muscles. And the main thing is that clinically, radiologically, it mimics a invasive malignancy. And in this case, a repeat FNA gave us better yield. Now coming to granulomatous thyroiditis, again women are affected. It's thought to be of viral origin. Usually it subsides on its own, but when there is the asymmetric thyroid swelling persists, then they come for FNA. And the first thing which catches our eye in the smear are these huge multinucleated giant cells. Sometimes you may even have 100 nuclei, and in this field now you'll be able to identify many multinucleated giant cells. You can have such clusters of epithelioid cells, colloid. You have the lymphocytic population, degenerated granular debris in the background. Giant cells are not just found in the granulomatous thyroiditis. It can be seen in other thyroiditis and even in malignancies. And granulomas, first thing which comes to mind is TB. It is seen in disseminated TB, but it can be seen in other conditions as well. And a word about acute thyroiditis, numerous neutrophils, just like any other abscess-like picture. It is quite rare, and FNA is rarely done, but if you do have an aspirate, you put in special stains to identify the biologic agents, and you can even give it for culture. And you can have it in, if it's more commonly, it's an extension from an adjacent inflamed tissue. So to wrap up, if you have a thyroid nodule, always remember that the biochemical, radiologic, and cytologic findings should always complement each other. In a thyroid aspirate, first assess the adequacy. If it is non-diagnostic, try and identify the cause and then repeat it and rectify it. If it is satisfactory, assess the basic components, colloid and cells, and to identify the benign follicular nodule, look carefully at the cytoarchitecture and more carefully at the nuclei of the epithelial cells. And if it's a fluid-only aspirate, make sure that you are not dealing with a nodule with cystic change. And if it's a prominent inflammatory infiltrate, identify the type of inflammation which is seen, correlate with the other findings, and then you know it's a thyroiditis. So thank you so much for your patience, and that is all about